Hi, this is Callie, and this is my presentation on systemic lupus erythematosus. We'll be looking at the clinical objectives, and those are the pathophysiology of the systemic lupus erythematosus, or SLE. We'll identify common presentation of the patient. We'll also identify differential diagnoses that can be related to SLE and how to differentiate between them. We'll discuss red flags along with important points of H&P, and then the diagnostic testing that will help us identify SLE, along with the treatment options, the need for patient education, and the follow-up care that is provided with SLE. So as we go, we're going to keep looking at the pathophysiology. We're going to see that systemic lupus erythematosus, or SLE, is considered a systematic rheumatic disease that is characterized by altered immune regulation that can involve inflammation in the multi-organ systems. This includes the blood cells, the kidneys, nervous system, and skin. Autoantibody formation is a key characteristic of SLE, resulting in significantly increased numbers of circulating autoantibodies with impairment in normal suppression of autoreactive B-cell clones. Children with SLE exhibit a marked increase in the production of antibodies that attack the body's DNA. This leads to immune complex formation and tissue body damage from either direct bonding in tissues, immune complex deposition, or combination of both. There is a strong link between faulty immune systems and SLE. While the exact mechanism is not known, there are many factors that are thought to contribute to its development. This includes genetics in the proposed individuals, like hormones and environmental aspects that are linked to immune dysregulation. There is also environmental factors that are thought to play a role in SLE developing. These include oral contraceptives, pregnancies, microbials that are viral mostly in nature, temperature, climates, exposure to UV light, and certain drugs like hydralazine and procainamide. So as we look at the presentation of SLE in childhood, we see that it's very rare. The incidence rate is only 0.3 to 0.9 per 100,000. Though it's rare, when SLE is diagnosed, it's more acute and severe in children than adults. There's higher incidence in Asian, African Americans, Hispanics, and Native Americans. And SLE is reported to have a median onset of 11 to 12 years old, with the population mostly of girls. So if we look at that, the ratio is 4 to 1 females to males before puberty, and after it's 8 to 1 females to males. So when we're going to be looking at the common presentation that someone comes into your office and you'll be seeing. So when we're working with patients that have SLE or we're suspected, we're going to look for common findings. And these findings include skin manifestations like pallor, petechiae, palpable purpura, and digital ulcers, a butterfly rash, which is scaly erythematous maculopapular rash covering malar areas extending over the bridge of the nose and cheeks, and that's the characteristic butterfly rash that we're seeing. And this rash may spread down the face to the chest and extremities, and the rash can have other lesions that are photosensitive, and it's seen in 95% of patients with SLE. So this is something that we can be first on the lookout for. Patients can also present with mucous membrane manifestations of the mouth and nasal septum. And the patient can also have like gingivitis, mucosal hemorrhage, erosions, or ulcerations in the mouth. And then sometimes at the border of the lips, there can be a silvery whitening of the vermilion border. And this can have some thickening, redness, ulceration, or crusting lips that can be noted. Patients may also present with joint tenderness from a non-erosive arthritis with tenderness and effusion. This painful non-erosive arthritis and arthralgias are common in both adult and pediatric SLE, and there may be a trend towards more overt arthritis with pediatric SLE, while arthralgias and myalgias appear more often in adult SLE. We're also seeing in children that there's about 40% of children are presenting with osteopenia, and it's quite often to see an osteoporotic fracture in 6 to 10 of the children that have SLE. The patient may also have cardiac disorders, which include pericarditis, myocarditis, and non-infected endocarditis. And this happens in about 17 to 33% of patients with SLE, does not matter what their age is. So then we're going to be looking at the H&P. And so when we start looking at important H&P features, you're going to about 70 to 80% of the patients with SLE develop skin lesions during the course of the disease. So that malar rash, or the butterfly rash that we were talking about, occurs in most of the patients. And this is the hallmark of the SLE disease. The rash is seen about 60 to 85% of children with SLE and is generally described as erythematous, raised, non-pruritic, and non-scarring. The rash ascends over the nasal bridge like we talked about, but does not go to the folds of the nose. So it comes from here and comes out. Acute and subacute cutaneous lupus rash can present anywhere on the body, but mostly occurs in sun-exposed areas. Patients with SLE should be advised to use sunscreens that are higher than 15. And mucous membrane involvement, hair loss, and Raynaud phenomenon are also common in these patients. So we're also looking that there is some visceral organs that are involved in SLE in the kidney. So we'll look at that almost all patients with SLE have immunoglobulin deposits in the glomeruli, and only 50% develop clinical renal disease. Screening for nephritis from urinalysis and serum creatinine measurement should be done at 3 to 6 month intervals. When a patient with SLE has a clinical or laboratory features that suggest nephritis, 24-hour urine for protein and a spot urine protein and creatinine clearance should be obtained. There is also something called neuropsychiatric SLE, and this is at least common in children as it is in adults. So within the first year post-diagnosis, 70% of children, as compared to only 28% adults, develop features compatible with the NP-SLE, so the neuropsychiatric SLE. Depression is the most common mood disorder in children and adults without apparent differences in prevalence between the groups. Approximately 20% of children with neuropsychiatric SLE will develop psychosis, which usually presents with visual hallucinations. Psychosis, chorea, or any type of encephalopathy occurs preferentially with pediatric SLE patients. Cerebral vein thrombosis is also reported in 15 to 25% of children with SLE, often presenting with a severe headache in lupus anticoagulant positive patients. So if we're looking at the neurocognitive dysfunction, we're going to see about 30 to 60% of all children with SLE have this. And then lastly, the involvement of oral and nasal mucosa ranges from oral to nasal hyperemia to painless oral ulcers of the hard palate, and the shallow nasal septal ulcers and rarely nasal septal perforation. So due to the location and painless nature of these lesions, sometimes the practitioner may overlook these findings as maybe benign or something that is not bothering the patient at the time. So when we go look at differentials, there's a couple that we have. So idiopathic thrombocytopenic purpura, anemia, or rheumatic fever. So the first one, ITP or idiopathic thrombocytopenia or purpura, can resemble SLE. It is maybe the first manifestation of SLE by months or even years. And some manifestations of lupus occur more frequently in association with a low platelet count in these patients. For example, neuropsychiatric manifestation, the hemolytic anemia, or the renal disease. Thrombocytopenia can be regarded as the more important prognostic indicator of survival in patients with SLE. And there's a clear immunological difference between antiplatelet antibodies found in the two illnesses. The differences in the autoimmunity directed against platelets among subsets of patients with SLE, especially with stratified according to the presence of APL antibodies. Similar to isolated ITP, both serum platelet binding IgG and platelet associated IgG are increased in patients with SLE with thrombocytopenia. However, these antibodies are also commonly present in the serum of patients with SLE without thrombocytopenia. So sometimes it's hard to differentiate from that, so we'll have to gather more information for those patients. We'll also look at anemia, and this occurs at the onset of SLE, and its recurrence rate will become low after 3 months of therapy. And it's a common hematological abnormality in SLE that's defined with low hemoglobin levels of less than 12 for women and less than 13.5 for men. It's categorized into the following: anemia of chronic disease, which is the most common form that we're going to see in SLE, so 60 to 80. Iron deficiency anemia and autoimmune hemolytic anemia can also be seen. So when they looked at the studies, most often they're going to find, as we talked about, the anemia of chronic disease, and that was at 37.1 of the cases. So low levels of erythropoietin due to chronic disease or renal insufficiency, and presence of anti-erythropoietin and autoantibodies are found in some patients. Furthermore, drugs, myelofibrosis, and thrombocytic microangiopathy are also implicated in the causation of SLE anemia. So this is something that could be caused by the lupus, or it could just be anemia on its own. So we have to continue to look at those extra signs and use the diagnostic tests like the ANA to see if that is something that is causing SLE. One of the biggest differentials would be rheumatic fever, which can also present like SLE. So patients present with fever, pain in the abdomen, heart problems, shortness of breath, or pain in the joint. Patients also develop ring-shaped or snake-like rash on the trunk and upper part of the legs, and they can develop skin lumps or nodules. So as we talked about, SLE has a big skin component, and so as rheumatic fever starts, we can also see that. Patients with RF can also develop a condition that affects the brain and nervous system called syndrome chorea. And so the symptoms of that would be lost control of emotions with also unusual crying or laughing, and then quick jerky movements that are mainly affect the face, the hands, and the feet. So if we're looking at that, well, the difference between RF and SLE, sometimes both the chorea can be the same. We're going to be looking at the skin rash, but you're going to be looking at RF, rheumatic fever, and seeing that it's diagnosed through a past history of strep throat and an ASO test. So when we're looking at that, the history of strep throat is part of the reason that you're going to find rheumatic fever, and in SLE, the sore throat is not in the past history normally. So we're going to look at diagnostics, and diagnostics of SLE begin with a high index of suspicion. So when we're looking at that, there's 11 diagnostic criteria for SLE, and if the patient meets at least 4, SLE can be diagnosed with 95% specificity and 85% sensitivity. The criteria include a malar or discoid rash, photosensitivity, oral ulcers, arthritis, serositis, abnormal ANA titers, and the renal, neurologic, hematologic, or immunologic disorders. So once SLE is suspected, the initial evaluation should include an anti-nuclear antibody test or ANA test. This is a highly sensitive test with positive results about 94% of the patients with SLE. So SLE is unlikely in a patient with negative results. However, since it has a low specificity and may be positive in healthy patients. Although most patients with SLE have a positive ANA results, most patients with positive ANA results do not have SLE. So the test for ANA has a high sensitivity, but we're looking at the specificity being really low. We're also looking at CRP, and CRP are C-reactive protein, and ESR are sensitive markers of chronic inflammation and acute infections in children with SLE patients, and they have found sometimes they can be inconsistent correlations between CRP levels and the SLE disease activity. Routine hematology and biochemistry tests are also used to monitor disease status for SLE, flare, and remission, and this looks at medication side effects and the chronic effects of chronic disease and inflammation. So like we talked about, when you're looking at someone with SLE, you may be looking at somebody that needs to have a urinalysis, and this can be done looking for proteinuria, hematuria, and examine for CAS, while urine protein to creatinine ratios, and this is also required for monitoring for treatment of lupus nephritis, which we'll talk about. So when you're looking at diagnosing SLE, where you're going to be looking at the ANA, a urinalysis. You can also do a ECG or a renal ultrasound if you want to find out if there's been damage, and that's when we're looking at that lupus nephritis. So red flags. So as we talked about lupus nephritis, that would be one of the main red flags. So if we get back a urinalysis with proteinuria or urinary cell CAS, that can indicate lupus nephritis. And this is often a presenting feature of pediatric SLE. In comparative studies of pediatric SLE in adult, the prevalence of lupus nephritis in adults with SLE is 34 to 48, with pediatrics being higher. Despite large variations between racial groups, most studies report the lupus nephritis to represent 50 to 67% of the children at a higher frequency than adults. So consequently, proteinuria and urinary cell counts during the disease are more common with pediatrics with SLE. Hypertension occurs in about 40% of pediatric SLE patients with lupus nephritis, and African American children, particularly boys, may have a significantly higher risk of hypertension than Caucasians. There is also a higher incidence of anemia in very young children, affecting 77% of patients excuse me, with infantile SLE, and this is a SLE that is prior to the age of 1, as compared to 35% of children with only that are older than 1 year. Leukopenia is also something that we're going to be looking at, and this could be a red flag. With the reported prevalence between 42% and 74% during the course of the disease, leukopenia occurs with a similar frequency in pediatric SLE as an adult. It can be less frequent in young children with SLE compared to pediatric SLE with onset at or after puberty. We're also looking at neutropenia, and this is similarly frequent in adult and pediatric SLE, occurring in about 12 to 15 children, and about percent of children, and 4 to 20% of adults. This has been associated with thrombocytopenia and the neuropsychiatric SLE in both pediatric and adult patients. Overall prevalence of thrombocytopenia appears to be somewhat higher in pediatric patients also. And we are going to be looking at 25 to 30% of pediatric patients with a disease onset later in life. And prior to developing pediatric SLE, children and adults with thrombocytopenia may have carried the diagnosis of ITP, and providers should be careful for any child with ITP who is found to have an ANA high titer. And this could be indicative of having SLE. So as we look at an estimated 50 to 85% of pediatric SLE patients also have dyslipidemia. And when you're looking at that, the LDL particles are smaller with active compared to inactive disease in pediatric SLE. So we're going to be concerned that they have higher lipids. And then genetics can also play a large role in inheriting SLE. So Caucasian children appear to be at a higher risk of being diagnosed with SLE. Genetic studies in pediatric SLE provide, for most part, confirmation of genetic variants reported in adult SLE and do not explain the differences in disease presentation. So genetics play a big role in how people can get diagnosed, and if your family has it, there's a good chance that you will also get diagnosed at the same time. Not the same time, but within the same amount of time. So when we look at treatment, we're looking at the immunosuppressive medication with pediatrics compared to adults that are looking at different kind of drugs. So drugs are going to be for children and adults are normally around the same. So except for the common use of methotrexate in adults than pediatrics. So adults are using methotrexate 31%, while pediatrics are 9%. Patients with the SLE of all ages older than 6 years are equally likely to be prescribed antimalarials. Adults and children with SLE are comparable in their use of nonsteroidal anti-inflammatory medications, except for the cycloogenase 2 inhibitors, which appear less to be prescribed to children and adolescents. So when we're looking at pharmacologic therapy, it's often aggressive but tailored to the severity of the extent of the disease manifestations. Although a few drugs are actually approved by the FDA for use in children. So if that's the case, we have lots of drugs that we can use with adults, but sometimes they're not approved to be used with children. So all drugs have potential side effects. The balance of risk versus benefit is always in the forefront. The antimalarials like Plaquenil and Erelin remain a staple for treatment of mild symptoms, particularly the rash and arthritis, and for disease maintenance therapy. NSAIDs are prescribed primarily for musculoskeletal symptoms and may be used for serositis. Oral and intravenous corticosteroids remain the backbone of most therapeutic regimens and are most effective for rapid disease control. More than 90% of all child SLE patients will receive corticosteroids at some point during their disease process. There are newer therapies that are coming out that have promise for SLE patients. The rituximab, it's a monoclonal antibody that binds and kills active B cells, is effective in the treatment of cytopenias, and rheumatologists also use this in combination with immunosuppressants for other disease manifestations. Unfortunately, right now it has not been tested on children, so right now it's not being used in children, but they said there's a great efficacy with adults and they would like to, at some point, use it with children. So after we diagnose the patient, what are we going to do? So we need to provide education. And as we know, education is critical, and this education, depending on the child's age and their ability, is going to be either to the child or their parent. So it's important for us to track the child's health and keep them involved with activities either around the community or with their school. So in order to help the child, it is important that to learn as much of like parents can about the disease, and they can recognize how it's affecting their child. Parents should be encouraged to track and learn to recognize the changes in the child's day-to-day health, and that may be a warning sign of a lupus flare. And this is also vital when creating a plan for your child when they go to school or when they go to daycare. So if the child is attending school or daycare, sometimes there's something called a daily care plan, and you want to add specific pages that are relevant for your child's school or activities, like contact information, specific health reminders, or needs. At this time, at times it's appropriate to talk with a child about their disease, so you want to talk with parents about keeping it simple and using age-appropriate language. If they use too large of language, small children may not be able to understand the nature of lupus, and most likely they're aware that something is wrong though. It's also important to stress that parents involve their child in making healthy choices about their care needs. And this also is like a positive approach. Allows the child to accept the illness a little at a time, and so it makes it fun. Maybe some rewards if they acknowledge their participation in their care. This may helps them own it, and maybe have them have a little more stake in it. So maybe they understand it better and they maybe want to participate more. So when we're facing challenges ahead, it's important that we remember that what is appropriate for school-age children. So if the child's in preschool, children are very literal at this point, and they may think, I'm sick because I was bad, or if I'm really good, I'll just get better right off the bat. And so don't give them a lot of information. The biggest points you want to let them know is no one knows what causes lupus, and having lupus is not their fault, and it's not because you did something bad. So once they're out of that stage and they get to elementary school, your child will start thinking concretely and abstractly. So they're going to also be beginning to realize that lupus is not their fault. It doesn't relieve their stress. And they may also expect parents to fix everything. And you should allow them to ask questions, make sure that they understand what you've told them, and important points to make would be like lupus is not contagious. Sometimes you're going to feel sore, tired, and achy. The doctor will give you medications to help with that. Some things will change, like you may like being able to spend a lot of time in the sun or participate in activities. So you're going to want to make sure you talk with them about putting suntan lotion on even when their friends aren't. And some things, be careful to wash their hands and stay away from anybody that's sick, because their body doesn't have enough immune response to fight off extra germs. Once they reach middle school, and this is kind of where we're talked about, it's kind of surfacing between that 11 and 12-year-old age. Your child should be able to make rational decisions and judgments. And so you can explain it to your child without becoming too technical, the names of their medications, the doses, what they're for, and how they work. And so when they're ready, you can ask the doctor to begin to speak directly to them at this point. And so the important points would be like, it's okay to ask questions about lupus or your medications, or even about the personal issues that they're having with lupus. It's important that you also you remind them to take their medications in the right amounts and at the right times each day. Try to focus on the good things that they're good at and what the disease does not affect, and don't give up on their goals and dreams. And so as we move from middle school to high school, and you also are facing, so this is, getting a little out of the pediatric realm, but we still see teenagers that are going to experience a wide range of physical and emotional changes as they move up and become independent adults. So when the crisis occurs, such as the diagnosis of lupus, some teenagers may react with expressions of anger, frustration, or sorrow. Others can become withdrawn. So when you look at the serious medical conditions that occur in teenagers, you want to start talking with the child's doctor. You must begin making all the decisions, and then you're going to try to hand it over to them. But this helps them, once the disease is stabilized, they need to have that they're you need to make sure that their opinion matters and that they feel like they're part of the decision. So maybe helping them have some degree of control over their lupus, as well as realize the impact of their choices. And so this is an essential time for you to talk with them, and especially as a provider and a parent. And you want to stress that they're going to be upset, that they're maybe not going to be happy with everything. But if you can keep an honest and open discussion with them, it's going to be helpful. and then encouraging them maybe to talk to the doctor and nurse. That may be helpful for them. And just remember that having a chronic illness causes pain and fatigue that can make any child or teenager or parent feel left out of the life that their friends or peers are leading. So if they're going to need that help, sometimes a support group or finding a outlet for their anger or for their frustration would be one of the better ideas. So as we work through the diagnosis, we're looking through education after we first diagnose this patient. We're looking at management and follow-up. So as we know, SLE is a lifelong disease and it's characterized by periods of flare and remission. Since the typical child SLE patient is an adolescent female, this addressing the usual challenges of adolescence becomes crucial to ensure that adolescents are making informed and correct choices. So as the onset of SLE occurs, we are going to start having more further stresses, and there are also maybe more comorbidities of disease that should be minimized. So disease manifestations, including the rash, the alopecia, arthritis, may be painful and lead to writing difficulties, along with the possibility of significant cognitive dysfunction that can make life even harder for people. Side effects of treatments can also make issues worse. You're going to look at systemic corticosteroids that are going to lead to weight gain, moon phases, striae, and acne. And while other treatments may cause alopecia or carry the risk of infertility. So it's not surprising that people, like when kids get older, that they don't want to take their medications or they're reluctant to go to school. So medical management of child with SLE differs between providers, but usually will have the same principal approach. Most patients will require the glucocorticoids and often immunosuppressant drugs with the aim at reducing disease activity while also preventing long-term toxicities. The diagnosis of neuropsychiatric involvement along with patients with SLE could be challenging since lupus mimics many other disorders. The most common clinical manifestations reported by the various studies were headache, cognitive dysfunction, mood disturbances, and seizures. They were also looking at headaches about 13% in children, and seizure and mood disorders were also 13% and 9.5% respectively. So when you're looking at these patients, when someone is diagnosed with SLE, you want to be looking for the neuropsychiatric symptoms along with it, making sure that patients aren't diagnosed incorrectly. The overall cost of care is considerably higher in children than adults with SLE. The estimated economic burden of pediatric SLE ranges from 146 million to 650 million annually in the US. In a study utilizing administrative databases from 2 tertiary pediatric rheumatology centers in the US, the annual cost of pediatric SLE was $14,944, excluding outpatient medication expenses. The cost was accrued mostly by hospitalizations, lab testing, and outpatient clinic visits, while emergency department visits continue to be only 1% of the total cost. So then we're going to look at the conclusions that we can make. So once again, we talked about there's no etiology for systemic lupus erythematosus. The common presentation was a butterfly rash with fever, ulceration to the lips. It's diagnosed through a positive ANA titer and collaborating symptoms. Differentials include idiopathic thrombocytopenia purpura, anemia, and acute rheumatic fever. The ANA and urinalysis for 24 hours are the main diagnostic tests that we're going to see used. And the treatment includes the use of NSAIDs, oral steroids, antimalarial drugs, immunosuppressant agents, and vitamin D and calcium that can help with the bone loss. Patient education is key for pediatric patients and their parents to ensure that they understand the disease process. And the pediatric SLE is less deadly now than in the past, but the burden is high for the families. So as we go through, we're going to look at my references, and then we'll finally get to the questions, and I will post these up on the board for you guys to answer. Please let me know if you have any questions. I appreciate you guys listening to me tonight, and I hope you have a good week, and I look forward to seeing you guys on the board. Thank you. Good night.